Good evening, everybody, and welcome to this ESSM third workshop webinar. I'm Mikkel Fode, and I'm the chairman of the ESSM Educational Committee, and this is really a pleasure for me to introduce the second webinar on managing paraphilic disorders with two true experts on the topic, Dr. Katerina Klapilova and Dr. Tillmann Kruger. So we look forward to this very much. I also, just before we start, want to remind everybody that this is a series of workshops, webinars, and we'll have the last one on January 18th on the impact of BPH treatment in sexual health. Also, I need to remind everybody that these webinars are the workshops that we were going to be having if we could have had a real conference this year. We will have an ESSM virtual conference from February 19th to February 20th, and we hope that you will attend there. Now, before we start, the main person organizing this virtual event is the chairman of our scientific committee, Giovanni Corona, and I'd like to give him the words for a few minutes before we start tonight's webinar. And after that, our president, Carlo Bitocchi, is going to also say a few words. Please, Giovanni.
So thank you, Mikkel. First of all, I'd like to congratulate with you and for all the hard job you did. We had a great success for the past webinars. I'm sure that even this one and even the new one, which is supposed to be in January, will be another great success. During this webinar, we essentially are going to analyze some very difficult and very common topic. This evening topic is a very hard topic for people involved in sexual medicine, so paraphilic disorders. We have, as Mikkel already said, very outstanding speaker. I'm sure that it will be a great success again, so enjoy the show. Carlo.
Okay, thank you very much and good evening, everybody. And first of all, really, I want to thank both our speakers that are really outstanding in this field. So Katerina and Tillmann, thank you very much really for giving us the opportunity really to explore this field in the best way. And I need to thank these two guys because they are really the people that are running these activities that it's very important for our society. As you know, in this year, we are managing as much as possible to have scientific sessions, and the only possibility is really to move through these webinars. And so these very interesting webinars are very well organized by both Mikkel and Giovanni. So thank you very much for both of you. I also would like to give you very brief information about our activities, mainly the educational and scientific activities that we are running. You know that we are running since more than 10 years a very important school for sexual medicine. And this is for us really one of our most important projects that we are very happy to continue to run every year. And unfortunately, this year we were not able to do it due to the circumstances because it is very important to do physically. And so we decided to postpone in the next year. And together with the ESSM advanced courses that will be combined to the usual School of Medicine. So the registration will be available soon on the website for this school that would be in the next year, 2021, the month of August. And so please be aware about this very nice appointment opportunity for all of you. I also want to give you information about a new project that will start next year, 2021. And this is our first year for the Academy on Genital Surgery. This is a project focused mainly on surgery and is a complete learning and on training program for everybody who want to improve their skills in the field of surgery. And it is very important because we have decided to do a very nice step-by-step improvement starting from a level 1 that is mainly on textbook and video library. Then we will move on a 3D model and then cadaver training. And finally, everybody will be happy to go for the fellowship in some specific centers of excellence. And so again, this project will be launched very soon in our website. And please, everybody is interested, just don't lose this opportunity. Another important educational offer from our society are the videos, and we have already a good number of videos in our library, and we are trying to improve this video library with more and more important videos, especially in surgery, but we also have videos on erectile dysfunction and other fields of the sexual medicine. And finally, the last things that I wanted to tell you about is the manual of sexual medicine. You know, we have the manual of sexual medicine, the syllabus of clinical sexology. Okay, two important news. One, we are renewing, so we are updating the manual of sexual medicine, and possibly end of 2021 or 2022, it will be ready. And the textbook of surgery is already on market. And so again, this will be a nice opportunity for everybody who's interested to have a look about this book. So I don't take any more time because it's time really to listen to our very important speakers. And so please, Michele, you are in the position now to start all the webinar. Thank you very much. I'll see you later.
Thank you very much, Giovanni and Carlo. And with these words, I'm very happy to now give the word to Katerina and Tillmann for the main event. And during the talks, you will be able to ask questions in either the Q&A or the chat box. I'll collect them and we'll post them at the end of the webinar. So please.
Okay.
Okay.
So you want to start, Katerina, to introduce yourself? Ladies first.
Ladies first. Thank you, Tillmann. Please share the screen. And dear colleagues, I'm very honored to be invited to give a part of this talk on this very important topic. My name is Katerina Klapilova. I work at the National Institute of Mental Health, and I'm a guarantee and founder of a program of primary intervention for people with paraphilic interest in the Czech Republic that is just starting. And I'm very pleased to be here with my brilliant colleague, Professor Tillmann Kruger, who can introduce himself now.
Hello, everybody. I'm extremely happy to be with you here tonight. It's great, and it's indeed a very difficult topic. It's great to have you here because we need you in sexual medicine also for these topics that are not easy, because there are not many people out there helping people with the paraphilic disorders and especially with pedophilia. So it's great to have you here tonight. I'm head of the Division of Clinical Psychology and Sexual Medicine, and I'm consultant of neurology and psychiatry at the Hanover Medical School. And I'm looking forward to have this time with you together. So, Katerina, I'm briefly going to show what we are talking about today. We have 4 parts, and we have to hurry up a little bit. But anyway, you can afterwards have a look to the presentation, of course, and you can also write to us if you have any questions. The first part will address the question how to diagnose paraphilias and how to interview in different contexts. The second will be how and why to assess risk factors in terms of sexual offending, because this is a major issue beside the disorder itself, to protect others, adult or children, due to the paraphilic disorder. Third, how to do consultations for patients, for clients with paraphilia, some general brief suggestions that everybody of you is able to do at least brief consultations for them. And finally, how to offer specialized treatment in terms of psychotherapy, pharmacotherapy, and we will have a very brief look at country-specific suggestions and tips. Katerina and me, we are in the happy situation of having novel prevention projects, and there are some countries in Europe that offer such kinds of projects, primary preventive projects like Paraphil in the Czech Republic, or Don't Offend, or I Can Change in Germany. All right, I hope everything is okay, and Katerina and me, we want to start with a question, and I think Daniela is going to show you the question. The first one is, how do you feel like with patients with any paraphilia? First, I feel extremely uncertain and do not know how to help. My heart rate increases and I'm sweating. Second, I talk to them briefly, but send them somewhere else, wherever that is. I don't feel confident to treat them. Third, I'm able to do some brief diagnostics and brief consultation. And fourth, I'm an expert and I'm able to manage these cases. So let us know.
Thank you everybody for voting. Just a few seconds more and then I will stop the polling. Thank you very much. I will now share the results.
All right. So at least we are among colleagues with the sexual medicine expertise. Katerina, I would say.
I see.
40%.
I see. I was presuming that there won't be so many people that are comfortable with the topic and working. And I can tell that we've posed these questions to the Czech specialists in the field of sexual medicine and psychological treatment. And they really did not feel comfortable with this. Only 20% told us that they really do feel really well prepared to work with this group.
Yeah, so that looks good. And we hope to improve it a little bit. But anyway, we have another question. This is a bit more specific. What should we do with people with pedophilia? This is a typical question that is used by large surveys in Germany and the Czech Republic. And the responses are quite difficult, so to say. First, they should all be in prison because they will sooner or later sexually abuse a child. Second, they should be under regular expert control, medicated by anti-androgens. Third, they should be all motivated to seek for professional help because they can have problems with controlling their sexual behavior. And finally, they should all have access to qualified professional help focused on helping them with control of their sexual urges and mental health issues related to their sexual preferences. So please vote.
Thank you very much. Just again a few seconds and then I will stop the polling and share the results.
All right. Again.
It was kind of suggestive question, of course, because that's the message that we wanna leave, I think. And thank you for that.
Yeah, that's the point. And I think, Katerina, you're going to briefly comment on this, that it is actually the other way around. If you ask people somewhere out there, if you ask people that are not familiar with it, and that's the point with terms to the work we have to do. All right, so we go on.
Right. Yeah, and next slide.
Katerina,
and yeah, I want to start with, we wanted to start with these two questions because as to our knowledge and also based on results on scientific studies, the stigmatization of these groups and low professional confidence are first barrier for good management of paraphilic interests and disorders. As far as we know, the key point is that there is a massive social equation of paraphilias with sexual offending, whatever crimes like sexual abuse and other crimes. And this leads to high stigmatization of this group in the population. For example, around 27% of participants agreed that even if person with pedophilia is non-offending, they should be better death or preventively imprisoned, which is really a proof of high stigmatized and vulnerable group. In a clinical population, it is better, of course, and obviously in your sample. However, still it pays that the clinical knowledge is highly based on work with offending individuals with paraphilia, and there is a low knowledge about non-clinical population of people with paraphilic interests. So There is a lot of also a treatment treatment tools are adjusted for work with rather offending individuals, and also the clinical knowledge as well. So there is a lot of people that don't work specifically with this target group that are afraid to work with this based on these knowledges. So also in an expert population, a high sample, there is a huge range of healthcare professionals would not be willing to provide professional help to people with pedophilic preferences, especially, which leads to the conclusion that people with paraphilia rarely seek help. And next slide. Next slide, please. Rarely seek help. And we've made several screenings in specific populations, like, for example, pedophilic community. And we were trying to look if this is really true, that there are some barriers on this side, why people with pedophilic interest do not contact experts. And yes, this was confirmed. There were barriers in terms of high stigmatization. So they have fear of being identified, fear of being reported and diagnosed, fear of medication, automatic medication because of their paraphilic interest. And they also do not have a big trust in expert competentness, and there is a lack of experts. So next slide, please. So the key message is in the beginning. It is really good not to mix paraphilic preference automatically with sexual offending. This is a highly vulnerable group of persons that should receive adequate professional help, because they have a lot of issues in a field of mental health, like depressive symptoms, suicidal tendencies, that derive from their preference that they did not choose. And it is also good to know that to offer them help is also for the sake of others who are potentially at risk of being harmed. As you can see, the sexual offenses are not in the majority committed by people with paraphilic interest. It's less than a half in meta-analysis, even less in our Czech data. However, as a clinician, you have to be aware and prepared, mentally prepared, that they could be in a high risk of sexual offending, and the part of your non-confidence might be based on that you don't know what it really means, how you should intervene in this case. So that's what we are going to show you and give you tips for. Next slide. So the very first step is a good diagnosis of paraphilia. And I think, and as I saw the results, that I should skip this part probably because you feel really confident in that. So let's take it really briefly. So first, what is a paraphilia? You can of course find different terms according to the manuals you use in your countries. This is an international audience. Also, we will talk about DSM-5 and paraphilia and paraphilic disorders, but you have also disorders of sexual preference in ICD-11. In some traditions, you can still use the non-used term sexual deviance, or you can tell other things. However, what it really is, it's a very general term, and the definition is also very general. That it is any powerful and persistent, which is important, sexual interest other than sexual interest in copulatory or pre-copulatory behavior with phenotypically normal consenting adult humans, which means that it somehow is showing us that it is something different than a norm, that is which is a discussion for a longer time than we have there. But Next slide, please. Next slide, please. Yes, thank you. But what is the norm and what is really rare and unusual is a hot topic. And as I told, we don't have many data about non-clinical population and paraphiles, but in the last decades, there have been several population-based studies, including ours, which is not the best, but that's what I have as a result that I can use. And here you can see that some kind of paraphilic patterns are not as unusual and rare as we would expect, especially in the male population. If you look at the prevalence, and this is a prevalence of proclaimed strong sexual preference. And also what was, the numbers are more impressive if you look at the prevalence per number of inhabitants, which is a quite big pool of people in our republic. And if you look at the numbers, how many of them, what proportion of them have sought professional help, this is the range from 3 to 15%. So it means really low percentage. Next slide, please. Our study is not the only one. There are brilliant Swedish, German, and Canadian studies I addressing here. But next slide. What does it tell us is that there is really a huge proportion of people with paraphilic interests in the population that do not seek help, do not commit sexual crimes, and also some of the patterns are not as unusual as we would expect. So in the newly concept of diagnosis of paraphilia and paraphilic disorders, you have to acknowledge that most people with atypical sexual interests do not have automatically a mental disorder. To be diagnosed with a paraphilic disorder, you have to have both criteria, A and B. So A, over a period of at least 6 months, so it's persistent recurrent. You have persistent recurrent intense sexual arousing fantasies, urges, or behaviors involving preferred paraphilic activity or target. So it's not only about behaviors. And these fantasies, urges, or behaviors have to cause clinically significant distress or impairment in social or other important areas of functioning. It means that the person has to feel personal distress about their interests themselves, or they have to cause distress to somebody else, or harm or injury, or their desires or behaviors have to involve unwilling persons or persons that can't prove consent with the sexual acts. Next slide. So this is the list or checklist, let's call it, of diagnostic categories and the paraphilic patterns, which is of course not exhaustive of all paraphilic disorders and patterns, because there is so many paraphilies that even I don't know. However, these are the main patterns you can meet and diagnose. I don't need to read all the things because you are familiar with this terminology, but but it is probably useful to divide them into anomalous sexual activity preferences and anomalous target preferences. That's what is in our historical tradition. And what is important in anomalous activity preferences is that it is the activity that has the strongest erotic potential and that is other than consenting normophilic behavior. Within the voyeuristic, exhibitionistic, frotteuristic disorders, it is important that there is involved stranger person as an object of sexual motivated behavior. And in these individuals, you can also see many times that there are problems in other than only sexual spheres with communication with the target of preference. In a sexual masochism and sadism, if it's non-consensual, then the erotic potential is focused on humiliating or otherwise making suffer the target of sexual preference, or the other way around if you are in the accepting level. And in animals' target preferences, the erotic potential, whatever activity is, the important is that there is not the target is not an adult consenting psychosexually developed person, human person. So the most prevalent is fetishistic disorder, where the non-living objects or some parts of body can be the object of sexual arousal, and we will be talking about paraphilic disorders the most, where the objects are prepubescent or prepubescent children. Other slide. So what is good to know? Comorbidities in terms of paraphilia are quite common. You can meet individuals that manifest more paraphilias. Distinction. You have to make distinctions between interest and disorders. That's what I told. In newer versions of manuals, there are deleted diagnostic categories which consist of consensual and solitary sexual behaviors. So, for example, in the example of sadism, BDSM practices, there, if consensual and not causing harm, this is not considered disorder. And you can also indicate if the type is exclusive or non-exclusive. So if, for example, the target of preference is only a child or also adults, we will be talking about that. But even if it's non-exclusive type, it can be only optional preference as well as in activities. It has to be internal part of their sexuality and sexual arousal, and it has to be equal or higher than normophilic preferences. The strength of paraphilia is assessed in relation to the individual's normophilic sexual interests and behavior, even if you are asking the person, or you can measure it via some kind of psychophysiological measures specific for sexual field, like penile plethysmography, that measures circumferential or volumetric changes of the penile reaction in males. I don't want to go to the details, but this was developed in Czech Republic by Kurt Freund, so I have to at least mention. So next slide. So the diagnostic process, the best diagnostic process is a detailed clinical exploration that should consist of the parts you can read in. However, it depends on which context you meet the persons. Of course, that if you are a specialist in the field of sexology or in some forensic setting, you will have to do the whole battery. But we will be here talking more only about sexual history taking and what can be different in this population, and about risk assessment measures which can help you to assess and work with factors that could lead to the sexual offending or inappropriate sexual behavior in this part. And also what is important is family and relationship history taking, because the paraphilias are not touching only a sphere of sexuality in the means of sexual functioning, but also romantic and intimate relationships a lot, and in your dyadic life. So next slide. So what to focus on in the sexual history taking? These are the areas that you These are the areas that you quite well know if you are used to do this thing. However, if you can meet some good indicators of that repeats in individuals with paraphilic patterns in these areas. So in the sexual and in intimacy development, you can find early or late onset of sexual activities. Also, there used to be latency between first and the second sexual encounters. What is important here that you should explore also falling in love and communication with the target of sexual arousal. So if they are able to communicate well and they have a good capacity to start and maintain relationships. Also, you can find their sexual and violent assaults in childhood, especially in those paraphiles that are offenders. Current sexual activity and sexual dysfunctions, you can meet them either lack of interest for dyadic sexual activities, or you can have here worse functioning in terms of dyadic sexual life with prevalence of various sexual dysfunctions. Content of sexual fantasies is the most reliable indicator for detecting paraphilic preference. So really do a detailed exploration of content of the targets that are there, if they are close to the person, if he knows them, what are the real activities that are appearing in the fantasy, how intrusive is the fantasy. So try to go for a detailed description. Also try to discover a whole variety of fantasies. If they are also some kind of normophilic ones, try to contrast their sexual arousability in contrast to paraphilic pattern and so on. So also we were talking about comorbidities, so explore various paraphilic tendencies. We use checklist for that, so that we don't forget anything and we know what we are talking about with the client. Sexual behavior, either offending or non-offending, what they really do and with whom, if there is a sexualized coping here. And I think Tillmann will be talking about it, is very, very important to know your report duties in your country, and you have to inform the client. So it is also important if you are talking with a person that has been already sent to you in the context of some kind of conviction or has been arrested for sexual assault, or if you are talking with a person that was undetected or did not commit anything. And so also pornographic consumption, if there is a problematic pornographic content or other kind of sexualized coping using these materials. Another slide. Okay, in terms of example of diagnosis of the pedophilic disorder, is good to use it's not to ask for the age of the preference, but use some materials where we can explain what is the social development, psychosocial development of the target. So we often use these Turner stages, and you can then agree on if it's a really prepubescent target, and then we can talk about pedophilic type, or if we are talking about pattern to pubescent, focused on pubescent type of girls or boys, or post-pubescent teleophilic preference. As you know, it can happen that also younger girls can look as higher stages of psychosexual development, and then it would not be treated as a paraphilic preference. So also you can use some kind of proportional graphs where you can talk about the proportion of fantasies of different different age of target, where you can really contrast then what is more arousing, more prominent, and so on. Very useful for PPG sets. The same thing, you can contrast the reaction to adults and to different groups. We use avatars, and this is not everywhere used as a supportive diagnostic and forensic material, depending on what's possible in your country. Next slide. So this is you have to recognize if the person is paraphilic or not. However, you have the person is coming to you to get help in the field of mental health or sexual functioning or some social skills improvement or whatever. But this is one aim, that you should offer a help there. But you have also another aim as a professional, which is to reduce the risk for problematic sexual behavior, which is for the sake of him as well as for others. So there are three distinct types of individuals you can meet. Sexual offenders that have been already detected by the system and they were referred to you, which is the most common. But you have also people that are coming voluntarily, undetected by the system, and they have different motivations to participation in the therapy and specific needs and different risk in terms of committing sexual offending. So next slide. Why is it useful? It is useful, of course, for you to plan and to be aware to do the treatment target aims. And also it is good to develop individual treatment plans. Risk assessment measures are, for example, not used in our country, and we are now starting to use them. But they are very commonly used in rehabilitation models of treatment of sexual offenders in a foreign country, like risk-need response model of Andrews and Bonta. And they are based on scientific knowledge about factors that can predict sexual reoffending. So they are not really used for non-offending groups, but they are useful for develop individual treatment plans and to know on what we can focus that could protect patients to go to the relapse or to cross the line. So first you can determine the dynamic risk factors and protective factors, and then you can use them for planning the intervention to reduce these risk factors and increase protective factors of the treatment. Next slide. So there is many tools. What is useful to know is that there are some static risk factors like paraphilia itself or some kind of that are non-changeable in life, like paraphilia in self, criminal history, and so on. But they are also dynamic risk factors like skill deficit, cognitive deficit, personality characteristics that can be related to the risk for sexual recidivism or first crossing the line that may be changed and targeted through interventions. And they are also acute or situational risk factors that you can't really target by the therapy, but you can make the client more stable in these situations, like when they meet the victim or they have an opportunity to offend, or there are no external barriers that would prove them, or they are in the big stress that could decrease their self-regulation skills and so on. So next slide. So I would like only to mention some because we are running out of time. So I wanna go really quickly. What you can find in the risk factors for sexual offending, for example, in paraphilic individuals, you can seek for emotional identification with children and strong cognitive distortions. For example, they attribute children as sexual interests and they have misbeliefs about sexual interaction with children. They take children as a good friends. They are thinking the children are more honest and sincere, prefer the children's against adults who they think that are, for example, not clear, not honest, unpredictable. In terms of emotional social deficits, there are feelings of loneliness, social rejection, non-acceptance of the paraphilic preference due to stigma. They think they are monsters. They have to abuse a child. That's what we were talking about. Also, they have incapacity to start and maintain emotional relationship, I mean, healthy one. Psychiatric comorbidities, of course. Another slide. So also important risk factors are poor self-regulation skills, and especially in sexual area. So general high levels of impulsivity, lack of problem-solving skills, and functional coping strategies to deal with distress. So there can be some problematic use of drugs or child pornography or other kinds of pornography, high sex drive and sexual preoccupation, other kinds of offense supportive cognitions and criminal history, like a hostility towards women or rape supportive cognitions, which can be for example, that all women want sex even if they tell no, or all women are sluts and they deserve rape, and so on. And we can't forget for opportunity and situational factors like victim access, emotional or social collapse, or lack of external barriers to commit some sexual problematic behavior. So next slide.
I think we have to skip it due to time.
Yes, this is the very nice casuistic where you can train if you can recognize at least some risk factors that could lead to the sexual offending to this client. But we will skip it now, and it's your turn.
Yeah, unfortunately we have to skip it, but you can do it afterwards if you look again at the presentation, and I try to identify the important risk factors in this case. All right, we're going to continue with part 3 and 4, just briefly how to do consultations for these patients. You have heard some things about diagnostics, as all the time you do a thorough clinical and examination and taking the history and ask for the masturbatory fantasies. These are quite good indicators of what kind of stimuli is the strongest. I'm going to briefly show you a media campaign from Germany, which I found was very good, because we have this big issue of stigmatization of these people, that every person who has a pedophilia is a child sexual offender. And I hope you can see it. We're going to start this quickly.
I feel like I'm still in love with that girl next door. I thought it was over it, but everything just came flooding back the last time I saw her in the stairwell. She gave me this smile. Hey, there's no way I'd do anything about it. I didn't even dare smile back. But I still can't get her out of my head. She's just the cutest creature I've ever seen.
All right, so now?
I don't know yet. Maybe I just enjoy being in love. Or better yet, pitying myself for my fate. But then it just feels awful again. Do you think I should tell her parents?
All right. So this is a new offer, Troubled Desire, to address the people with pedophilia that can be done online. This is online psychotherapy in, I think, 5, 6, or 7 languages, because we know that it's not easy in every country to address this issue. So again, we all know the Blizzard model, but some general brief suggestions for dealing with such kind of patients, which is not that easy. First, keep in mind their predominant emotions. The people that come, they often feel shame or fear of rejection. So you give the permission to talk about their very special paraphilia. It might be pedophilia or something else. Second, be self-aware of your own attitude, possibilities and limits. That's a little bit, again, the permission. So what is possible in your office? What is your time? And which kind of diseases can you treat? But at least you can do the P and the LI, the permission and the limited information. I think, or we think, that this should be the minimum of providing help to these people. Of course, if you feel too inexperienced, be confident, listening and encourage, but don't force yourself if you feel too much aversion towards this kind of people. I have many psychologists in our clinic, and some of them do a lot of trauma therapy, and others work in my projects with the prevention projects, and that work with potential or even real offenders. And it's not easy to mix it, to treat, to do trauma therapy on the one hand, and the next day doing this work in the primary prevention. That's not that easy for everybody, so you have to see what is possible for you. The LI provide educational information about sexuality. Katerina talked already about it, about these different orientations, paraphilias, about problematic behavior, different forms of offending, online and offline. Online offending is a big issue, and the police is not able anymore to handle all these images that are stored on the computers. So it's a very big issue in every country, I think. Talk about sexuality of children and adolescents. Sexual behavior interests are autoerotic, aligned with peers, emphasize that the right responsibility does not act on curiosity of children, inability to provide consent. So some important points. And in general, so if you try to offer help to this kind of people, there are, of course, the question of some organizational aspects that Katerina mentioned. So what are you able to talk about in your country? Are you able to talk about the history, about maybe offenses in the past, or are you not able to talk about because you have to report all of them? Then sexuality and dissexuality, problematic sexual behaviors, risk factors, the static ones, the stable ones, or the dynamic ones, and then the acute ones in the situation. And finally, medical treatment options. I'm going to briefly mention them now at the final part. How to offer specialized treatment. I mean, there are some centers in Germany, at least 11, 12. There are some in Czech Republic and maybe in your country as well. And I think we need these networks because it's a difficult topic. It's a difficult treatment. You need the sexual medicine expertise, but you also need the psychological, psychotherapeutical expertise in terms, at least if you want to do the specialized treatment. So I'm going to skip this one. And how does it look like? Course of treatment is not that complicated. Here are just as 2 examples, the 2 projects from Czech Republic, paraphilic, and the Don't Offend. You can see they use a little bit the same symbols here. That's great to see. We try to have a network in the entire of Europe. So there is a telephone or a anonymous email contact. There's a personal meeting with a pretty extended diagnostic procedure. It is at least half a day, actually 2 half days in Germany. So that's quite a bit. There's group and individual psychoeducation, about 10 sessions. And then there is group or individual psychotherapy. And most important, there's also aftercare. Many topics. I'm gonna not going into the deep of all the different psychotherapeutical issues, but what I can tell you, it's not only sexual medicine specific, but we have topics that we have everywhere. We need to build up motivation, for example. We have to talk about emotional skills. So all these are topics that we know also from borderline personality disorder or depression as well. So I want to encourage those that have some psychotherapeutical expertise, because many of the topics are known. And then in addition, of course, you need the specific sexual medicine, sexual therapy expertise. So how does it work? There's a very dense contact with the therapist. There is the need of immediately omitting any offending behavior, if there is any, or in many cases, there is at least use of child abusive images. Then there is psychoeducation and long-term therapeutic alliance. We want to decrease some important points, like Katerina already mentioned, problematic attitudes and beliefs, isolation and loneliness. It's not good that if these people are lonely and isolated. Problematic coping strategies and sexual preoccupation. And on the other hand, we want to increase empathy for children, self-esteem, social contacts, especially to adults, problem-solving skills, self-regulation, and sexual regulation. All right, in the end, some brief words to pharmaceutical options. General principles. All of you need this excitation and inhibition model that you can use for psychological issues and factors, but also for the neurobiological ones. And everybody of you knows that if we block testosterone, or if we increase, for instance, serotonin, we are able to have inhibition or a decrease of excitation of sexual processes. And there is a simplified schema that we use in Hanover with 3 levels. The first one is in cases of a person that is still able to control his urges, but who's saying it's not that easy. Would be good to have some support. Increasing the serotonergic tone might be good to use SSRIs, to use, for example, sertraline. Some of my clients use cypertron acetate, an anti-androgen well known among the urologists, blocks the testosterone receptors. 25 to 100 milligram per day might work pretty well in those cases with high urgency and the people that and where you need some time until psychotherapy works. And finally, for the very hard cases, you can also use, at least in, for example, the triptyline in Germany, but you can also use others, the GnRH analoga, which you inject every 3 months. And this is maybe the strongest drug that can decrease your sexual drive. And you can even combine these different levels. All right, this is just an example. I'm summarized this person from the Don't Offend project who had a very high frequency of masturbation 5 times per day and regular use of child abusive images. So he was then in my office. In addition to psychotherapy, we decided to add a drug to have a quick response, and that he's able to quickly stop the behavior, stop using these kind of images. And although he had some depressive episodes in the past, there's of course the danger of even promoting the depression by giving anti-androgens. We decided to give level 2, so to give cypertron acetate, and you see his sexual drive decreased from 65 to about 10. His sexual function went down actually, but his back depression inventory, which I took because he had depression in the past, also went down, not because even his depression got better, but he was just simply released by the feeling that the sexual urges were not that strong anymore. That's the reason. That's just some control parameter. Just briefly, what I want to mention, Lancet Psychiatry, one of the best journals in psychiatry. There's one of the first and very few randomized controlled trials with a GnRH antagonist, Degarelix. I think that's well known among the urologists, and it worked quite well. Within 2 weeks, a very significant and strong reduction of sexual urges, a reduction of risk factors. They had a combined composite risk score, and this went down quite nicely. So side effects, I think I'm going to skip this, but think about the sexual ones. Of course, there's also erectile failure. That's the other side of the coin. Mental side effects of this drug, like depression, fatigue, and somatic side effects, metabolism, sweating, bone and muscle loss. So if you take level 2, or at least if you take level 3, you have to care for these parameters every 3 or 6 months. So this might be really a topic. But anyway, psychotherapy plus these drugs for the very severe cases might be very useful to avoid child sexual abuse. All right, maybe you have 1 minute, Katerina, to show the slide where to find which kind of help.
Well, I think this is just made for you because you don't have probably opportunities in your country to send somebody into specialized treatment. But here you can see self-management platforms, good webs, and specialized treatment offers in some countries that you can look. So if you don't feel for specialized treatment, for example, you have something where you can address your patients, and it's good to know where to find it. And it's good to offer even psychoeducational self-management platforms that can really help.
Yeah, the RCT, for example, that came from Sweden, from the Prevental guys. So this was a very important and very good study. And as I mentioned, in Germany, Kein Täter werden or Don't Offend, Trouble Desire, the online psychotherapy. And we also have another project that is called I Can Change. That means that is a preventive project for adult people that have sexual offending or are near to sexual offending other adults, so to avoid rape. So this is a very new project. So I can summarize. First of all, check your attitude towards people with paraphilias and towards people with pedophilia in particular. This is more than we think. Maybe not everybody can do this kind of work, but we hope that many can. Begin with careful clinical diagnostics and look at the risk factors. Educate patient, and if possible, also the social environment regarding sexuality, risk factors, potential precursors of sexual offending. You have to know, normally you cannot change a sexual preference, but you can initiate CBT, psychotherapy, that may address risk factors, that may increase behavioral control, and if possible, improve sexual relationship to adults. So many of them still have some interest towards adults, some percent, and they have relationships, and many of them are not good, but you can improve them in psychotherapy. Talk about the possibility of pharmacological treatment. Many of them are not their whole life in pharmacological treatment. Many of them are only in 6 months treatment in my office, and then psychotherapy is strong enough to do the rest. We talked about the preventive projects, and any help is appreciated. And all right, so it took some time to explain such a difficult topic, but I hope we still have some minutes left to discuss some open questions with you. Thank you very much.
Well, thank you very much for this wonderful presentation. You're right that it took most of the hour, but I certainly think it was worth it. I think we can do a couple of questions either way. The first one, do we have to use the implicit model for dealing with paraphilic patients, or do we use another model? This was in Tillmann's talk, but either of you obviously.
Katerina, go ahead.
Mm-hmm. No. I don't think there is a need to use this model. It's only useful explanation. What should you do in the very first contact if you are not specialized worker? I think it means that the permission and psychoeducation and to resending to the specialized treatment can really help. This is important to explore the first steps only, in my opinion.
All right, thank you. The second question, in the pharmacological case, why was chosen to use anti-androgens instead of, for example, SSRIs? They also reduce sexual urges and improve depressive symptoms. So this is a very specific question. As you said, anti-androgens can induce depressive symptoms. Can you explain the reasons one would have to decide to use anti-androgens?
Yeah, I always discuss with the patient, and this was one who said that he had several risk factors. The one was high frequency of masturbation, so there was a high sexual drive and urge, and the other one, there was still some kind of abuse because he was using abusive images. And if the police would known, that would be the end of the psychotherapy, he would be in jail or somewhere else. So this wasn't a behavior that needed to be stopped immediately. That's the point. So it was a serious case. If another person tells me there is a strong drive, but I still have my behavior under control, then I would decide maybe the sertraline or paroxetine is enough. And so at least in Hanover, I always start with level 1, usually, except for example, this case, and then I go to level 2 or 3 or do combinations. In other cities, like in Berlin, for example, they do it the other way around, which I find quite discussable. They start with level 3 because they say it's always urgent. But all of us know that these drugs from level 3 or 2, they have side effects and we have to control from them, including depression, bone density goes down after 6 or 12 months and so on, you know, all these side effects from urology. So these 3 steps are carefully to be explored and to be discussed with the patients. And I think then you can together decide which level might be the best for the first start. And you can see the patients after 2 or 4 weeks again, and then decide what is necessary.
Great, well, thank you. There are many questions, but the time is running, so we do have to end the webinar. I'll give you the last comment. It's one of the participants saying, great webinar, thank you. And I really think it was. So thank you both of you very much for your time and contribution tonight. I think this was very interesting and very beneficial to the listeners. Thank you.